Okay, now we are continuing our Viva questions on benign prostatic enlargement, surgical treatment options. Let us continue with the same scenario what we discussed for the medical management. The patient which whom you have started on tamsulosin and finasteride combination is got 70 cc prostate, quite high IPSS, 28 out of 35, QOL 5 out of 6. He presented with acute urinary retention, as I said, in 4 weeks' time. You have given him one more option for TWAC, but unfortunately TWAC failed. How are you going to manage him?
Yeah, we'll see him back in the clinic, go through the management options again. He does have a catheter now, and he's got a prostate size of 70 cc, severely symptomatic group. Then I will counsel him next about the surgical treatment options of fluid tract symptoms. This can be, broadly speaking, either by with the size of his prostate, take into account his comorbidities and take into account if he does take any anticoagulants. One of the first options I will mention to him, transurethral resection of the prostate using bipolar. I will counsel him about the technical aspect of this procedure, about the benefits and about the side effects, and I will provide them with the bowel information leaflet. And I will also counsel him about alternative minimally invasive options. This can either be Greenlight Laser prostatectomy, Hollium Laser enucleation of the prostate, and non-ablative options such as the prostatic Eurolift surgery or Resume, and other options I will mention to him also, prostatic artery embolization.
Okay, you initially mentioned about bipolar TURP. What is the advantage of bipolar compared to unipolar?
Bipolar TURP has shown from the Cochrane reviews studies has a comparable effect on similar to the monopolar TURP in terms of IPSS score and Qmax, but it does have an advantage by in the peri-operative complications, less transfusion rate, less hospitalization time, and less catheterization time.
Okay, you need to say mainly about the elimination of TUR syndrome, which you mentioned. Lower clot retention and no big differences as far as the urethral stricture. That was a very surprising finding because we thought that monopolar means the current is conducting through the tissues up to the earth plate. Bipolar means the current is locally looped, so urethral stricture should be less, but unfortunately it's not so. Maybe it's all due to the size of the scope. What are the types of bipolar loops possible? Any types like true bipolar, quasi-bipolar?
So I just lost you for a second or so. Sorry, can
the question is, what are the types of bipolar resection loops available?
Oh yes, there is two technologies behind the bipolar machine. There is the true bipolar and the quasi-bipolar. The true bipolar, where normally in the bipolar technology there is an active and a passive pole. The passive pole in the true bipolar in the resectoscope itself, and this is in the Jarus technology, where in the quasi-bipolar, it is in the sheath, and this is normally in the TURS technology.
Okay. If you are doing TURP, what are the methods by which you can do the procedure intraoperatively?
Initially, in the appropriately anesthetized consented patients in a lithotomy position after administration of the antibiotics, if indicated, and completing the whole checklist, I will perform a diagnostic cystoscopy first, outlined the bladder and ureteric orifices, the bladder neck, just estimate size of the prostate, and mark not beyond the vermontanum, and then switch to 26 French resectoscope and perform a systematic 360-degree transurethral resection prostatectomy using the Blandy technique, slowly but efficiently to achieve both adequate resection time and adequate hemostasis at the same time, and evacuate all of the chicks and send them for histopathology, and ensure after that just meticulous hemostasis, and conclude with a 3-way catheter, 22 French with the 30 mils in the balloon, and start the irrigation.
So what are the different methods by which you can do the resection?
There are different anatomical methods has been described in the literature. I'm aware only about the Blandy technique. There are other techniques available, but no, I cannot recall any other names.
Okay, quite a rare question, but it's better to know. There are 4 techniques, including Blandy, 5th one. So the other 4 which have been mentioned were Nesbit's, Alcock and Flock's, Moormeyer's, and Brand's. How to remember this is, Nesbit starts from 12 o'clock. So it's more of the anterior one, and then slowly going to the lateral lobes, and then coming to the median lobe in the last. Usually we don't do Nesbit's in the normal practice. The Alcocks and Flocks you can remember because that's all the named vessels for the blood supply to the prostate. So the resection starts at 9 o'clock and 3 o'clock. This is one of the commonest surgeon's preference, and nicely resect up to the bladder veru, so that that creates a nice channel, and then you can do the anterior part, posterior part later. But if the patient has got significant median lobe, the better methods were Moormeyer's and Brand's. Moormeyer's is the Alcock's and Flock's modification. It's almost similar to Alcock's and Flock's, but only thing is we will complete the median lobe and then go back to 9 o'clock and 3 o'clock. While Brand's method starts with median lobe and then complete the floor, then lateral lobe, and then go to the anterior if needed. There are few surgeons who leave a strip of anterior prostate unattended, but there is no big evidence behind it. Okay. Is there any role for bipolar vaporization of the prostate?
Yes, it has. There is nice guidelines also recommend this, the vaporization of the prostatectomy, and that's using the mushroom technology just to vaporize the prostate tissue. It does have shorter operative time and less bleeding as well, and it's recommended for a prostate size up to 80 cc.
Okay. And coming to the vaporization of the prostate with other energy sources, what others you have?
I'm aware of the Greenlight Laser vaporization of the prostate, and there is other energies such as the Hollium Laser and the Fullium Laser vaporization as well. That's enucleation of the prostate with the Hollium Laser.
Explain Hollium Laser enucleation.
In the Hollium Laser, that use Hollium Laser, which is a YAG laser, pulsed laser, which is anatomically enucleate the prostatic adenoma tissue from the capsule, followed by morcellation of the prostate tissue from the bladder. It does have significantly higher operative time compared to the bipolar TRP, but it's a comparable results in terms of IPSS score and Qmax and quality of life, and it does have less side effects profile, less bleeding, less hospitalization and catheterization time and less TR syndrome as well.
Okay, the Hollium Laser wavelength is 2140. Try to bring in some values and some abstract knowledge that will further improve the marking. The examiner will get an idea, okay, you are able to have a good memory power and you're able to remember the abstract things apart from kind of a nice linear flow of the clinical management. Okay, good.
Yeah.
What other energy sources can be used to enucleate the prostate?
Fullium laser enucleation of prostate, and that use it's a very recently it's been used, and it showed it does have comparable results. Fullium laser, it comes in a wavelength of 2013. And it does have a good comparatively to the Hollium laser enucleation. It's found to be adequate and faster in terms of enucleation, but it does show comparable results in terms of IPSS score, Qmax, and quality of life.
So thulium fiber laser is 1940 and thulium YAG laser is 2013. So you can remember both. What other possibilities available for vaporization?
The Greenlight Laser, and that use a KTB laser, which comes in a wavelength of 532. It's a different from the Hollium laser. It does absorb by hemoglobin, where in the Hollium laser it absorbs by water or saline, and it does have the vaporization effect or the tissue effect 1 to 2 millimeter. The disadvantage is there is no resectable tissue available for histopathology, but it does have a less perioperative morbidities such as blood loss and hospitalization, catheterization time, comparable effect to bipolar TRP. That's evident from the Goliath study, which compared the Greenlight laser to the TRP. They only excluded the patients who are on anticoagulants, and it does show operative rate of 4 to 5% over 4 years, compared to the TRP, which is normally 1 to 2% a year, equivalent to 7% in 7 years' time. Yeah,
the numbers when you are saying 532 for Greenlight, they're all nanometers. And the lasers are usually very good for patients who are on anticoagulant because they are quite good hemostatic, especially the Greenlight laser. So any patients who had previous antiplatelets or anticoagulant therapy, they have to be adequately stopped, but Greenlight laser is quite good. As you said, in spite of this factor in Goliath study, they have excluded the patients on anticoagulants, and they included only the patients less than 80 cc. I think they got the phase 2 Goliath study where the patients between 80 to 120 cc, those who have previous retention, those who have previous antiplatelet or anticoagulants or previous UTI also included. So we may see the results later. Okay, apart from whatever we have discussed, is there any other energy source suitable for this patient?
The other options, surgical options available for him, the non-ablative options, or there is the ablative options, which is the Aqua Ablation and the Resume, and there is the non-ablative options, which is a prostatic Eurolift and prostatic artery embolization.
Okay, explain Resume.
Resume is technology which works by convective water vaporization, and when it comes in contact with the tissue, the steam phase turn into a liquid phase, and that has an ablative effect to the prostate tissue. It's normally done under either local anesthetic sedation or general anesthetic. Has a very short operative time with significantly less sexual side effects and comparable effect on the IPSS score, quality of life. This was evident by the McVeary study, which is studied the resume patients against sham, and it was found there is results support the use of resume in those patients, and the side effects, as explained, very minimum in terms of sexual side effects, hospitalization. Normally with the resume, patients will have to have a catheter for a few weeks, and then they will have it removed subsequently. So it will be a minimally invasive options for this gentleman.
So how resume works? What is the mechanism?
It works by water convection method. It's a convection of the water vapor, which will have the ablative effect on the prostate tissue.
Yeah, it's a convective water vapor treatment. A thin needle is deployed, and when you fire, the needle up goes to exactly to the same depth, and the water which is heated externally is injected via the needle over 9 seconds, and automatically after 9 seconds the needle will withdraw by itself, and it causes cell death and result in tissue volume contraction without obvious necrosis. That is the main advantage of it. And approved by NICE in June 2020, advised between 30 to 80 cc prostates. Good for moderate to severe LUTS, typically with IPSS 13 or above. Okay, you mentioned about Aqua Ablation. How Aqua Ablation works?
Yeah, Aqua Ablation, this works by high frequency water jets type method, which has an ablative effect on the prostate tissue, sparing the blood vessels. The technology itself comes, it's a robotic arm which has a truss biopsy, truss scan, and a handpiece with integrated cystoscope, and perform the procedure simultaneously. It's normally done again under local anesthetic or sedation. Very short operative time. It has been approved by NICE recently. The only thing there is, the patient has to be counseled about the risk of bleeding afterwards, because the technology does not allow diathermy after the procedure. Some in the literature, some people have tried or performed subsequent cystodiathermy after the Aqua Ablation, and some relied only on the catheter traction. But the patient has to be counseled appropriately. The study has been the technology has been supported by studies of Water 1 and Water 2, and it showed a reoperative rate of around, I think, 2 to 4% in the period of the study, which is around, I think, 2 to 3 years.
Yeah, mainly the Aqua Ablation works by the principle of hydrodissection, and it ablates only the prostatic parenchyma. As you said, it maintains the collagenous structures like blood vessels and also surgical capsule, and it's done with ultrasound guidance and robotic operation. patient should be anesthetized, at least in LMA, because a slight movement of the patient will jeopardize the complete procedure. So it can't be done under local anesthesia. IV sedation also is not a very suitable one. After the procedure, patient needs a Foley catheter, and the light traction can be used for hemostasis, or a patient need a very formal laser hemostasis or a TURP rollerball hemostasis. Water 1, water 2 studies supporting that. NICE guideline September 2018 doesn't really approve the Aqua Ablation, but it approved for the Aqua Ablation should be done under clinical governance and audit. So it should be done under supervision.
Understood. Okay.
How prostatic artery embolization works?
This is normally done using an angiography first to outline the blood supply of the pelvic organ, including the prostate, and a selective embolization to the internal iliac arteries or the fine blood supply to the prostate, normally done, and it's a long procedure done by interventional radiologist. It has to be discussed initially with an interventional radiologist and a urologist for patient selections point of view. The access normally either from the groin or from the radial arteries, and the material that they use for embolization, I think polyvinyl alcohol, that's the material used for the embolization. Has been approved by NICE. It's normally reserved for patients with urinary tract symptoms with a prostate size of 30 to 80 cc who are not fit for any other treatment options or would like to consider this as an option for them. It's been studied and supported by UK robust studies, which was an observational studies, retrospectively compared the prostate embolization group against the TRP, and it was shown that there is a comparable results and less hospitalization time, and it was tolerated by patients, and it does have a good impact on quality of life, but it does have a complication rate on around 5% and a reoperation rate of 18 to 20%.
Okay, so the last one, what about Eurolift, how it works?
Eurolift is an ablative method where the lateral lobe of the prostate encroaching laterally to obtain a wide open prostatic urethral channel. This is using a clip and or an implant, and beyond the implant there is a permanent a stitch goes laterally to the prostate capsule. It can be done under local anesthetic, sedation, very short operative time, comes in an integrated handpiece cystoscopy, and normally the numbers of the implants somewhere between 2 to 6 implants. Patients stay after the procedure for a few hours and then go home, sometimes without the catheter. So it does have less side effects profiles on sexual function and a comparable IPSS and QMAX quality of life outcome. That's supported by NICE, so it's NICE approved, supported by the LIFT studies, which is 4-year studies, which showed the same less side effects profile, less hospitalization and perioperative complications, and a good impact on quality of life and IPSS parameters. It can also recently, I'm aware of the BULSA study, which the outcome of Eurolift on patients with acute urinary retention, and it's shown that it does decrease the catheterization rate by 81% on those patients who had catheters before the Eurolift procedure.
So the patient which we are discussing has got a median lobe. Will it affect your choice of treatment?
He is he's fit for all of these surgical treatment options. Currently the Eurolift, according to the NICE and the AU guidelines, does not encourage using Eurolift in a patients, or should not be offered. Eurolift should not be offered to patients with a middle lobe. But I'm aware of the study, I think the mid-lift studies, which has shown that the Eurolift can be used for those patients with the middle lobe with a comparable outcome. But as I said, it's been encouraged by NICE and the AU. The patients with middle lobe should not be offered this procedure.
Any other options you are aware of other than what we discussed till now?
Yeah, there is the I-tent and urethral stent. Currently, again, NICE approved, which involve using a urethral prostatic catheter for patients who are not fit, who does not want any surgical treatment options for the lower tract symptoms. I'm aware that the catheter has to be removed or replaced regularly. It can be done under local anesthetic, and it does have very less complications or side effects. Hence, it doesn't involve any resections. But again, the patient has to be counseled about it appropriately.
The I-tent doesn't involve any catheter. The placement of I-tent, the patient may need at least like a sedation, or at least from the surgeon's learning curve point of view, maybe a short anesthesia so that it's appropriately placed. Removal doesn't require any specific anesthesia. So the I-tent device, once appropriately placed, will give 3 incisions like Turner-Warwick incision, like Mercedes-Benz sign. And then removal can be done with patient being awake. It's uncomfortable procedure, but it's doable under local lignocaine jelly. The I-tent can be removed after 5 days in place. So there is no involvement of any catheter in I-tent.
Okay.
What do you know about the prostatic stents?
Yeah, the prostatic stents, that involve insertion of it's a permanent prostatic stent to obtain a wide channel in the prostatic urethra, normally reserved for those patients who are very comorbid, not fit for any surgical treatment options. Can be done under regional anesthesia with less operative time and less complication time. There is side effects involved with the stent, such as incrustation, migration, pain, leakage, and difficulty replacing the stent subsequently. Sorry, I have only this information about it.
Yeah. Bring at least 2 named prostatic stents like Allium and Mamocath. Both are well proven in the ureter also.
Yes.
But it's not a very excellent choice, maybe good for people who are not very suitable for any procedures, heavy comorbidity, but doesn't want to have the catheter in place. There is another new prostatic stent by name Exime, which is now in trial by Rocomed. and all three have equal discomforts, and need to change will be quite difficult. Memocath and Allium can be left for longer term, while Exime stents, the initial approval is only for 30 days or 1 month, and then now they are slowly trying to push it to every 3 monthly change. It's almost like a patient on a chronic bladder catheter instead of the continuous draining catheter. The Exime stents will help to drain the bladder without anything externally noted. Maybe a good choice for a patient who has got some mental debilitation, where they are not pulling the catheter, they are not creating traumatic hypospadias, etc. What about prostatectomy?
Yes, yeah, prostatectomy. NICE guidelines does recommend or does mention open prostatectomy, Millen's prostatectomy for those patients who have a prostate size greater than 100 cc. After we counsel the patients or try to refer the patients first to centers where they can do minimally invasive techniques such as the Hollium. So it is approved by NICE or recommended by NICE, and it's also mentioned in the AAU 2022. However, this procedure does have a longer operative time, higher morbidity and hospitalization time, and blood transfusion rate. Alternatively, I'm aware that patients who have prostate size greater than 100 can be also counseled about robotic simple prostatectomy as an alternative to the traditional open Millen's prostatectomy.
Yeah, robotic simple prostatectomy you should bring into the table for discussion, because it's quite a recent one. It also helpful for a robotic surgeon to improve his pelvic robotic surgery numbers, which will improve the expertise, and it's just mimicking the transvesical Millen's prostatectomy, but with better vision, better hemostasis, and better approximation, and patient will be having a better outcome, maybe through robotic. Maybe it won't give a good outcome in everything, but things like less blood loss, less hemoglobin decrease, less transfusion, less stay in the hospital, those things can be ticked off. There are some very experienced institutes who have tried already a daycare robotic simple prostatectomy, but this is all only for the sake of completion. Good. Apart from transcapsular milling, transvesical frere. So understand both the techniques. So sometimes the examiners will be happy to discuss the open simple prostatectomy for completion. This whole scenario can present in 2-3 ways. Sometimes the whole thing will discuss only monopolar, bipolar, TURP complications, TUR syndrome. Sometimes it will be only on newer modalities like PAE, Aqua Ablation, Resume, and Eurolift. And sometimes we will just stick to the open prostatectomy and laparoscopic or robotic assisted prostatectomy. So prepare in 3 forms.
Okay. Yeah.
Good. Do you have any questions before we complete?
No. That was very good. Yeah, maybe as you said, like, just I will go through again the technological parts, because if it comes even in the technology, that would be I should just be prepared for it as well. And just fine tune some of the numbers and the technological aspect of it. But yeah, it was very good discussion.
Yeah.
The BDH, it's become now my favorite as well. So it was very good. It's very good that we covered almost everything.
Yeah, just go through the numbers cutoff. For example, open simple prostatectomy, the size cutoff is more than 80 cc, but you said 100 cc. And similarly, if you take Eurolift, previously the Eurolift cutoff is something like 100 cc for NICE guidelines, 70 cc for EAU guidelines. But now the latest NICE guidelines 2021 has revised the size to 80 cc. So just try to get the up-to-date numbers. And I think Resume and Eurolift has a space to play for long term, but Aqua Ablation is still under trial, Exime is still under trial, iTind is approved by NICE, it is presently under consultation, where you can do iTind in a clinical governance audit based setup. and anybody can write to NICE if they have any concerns or if they have any output to that. Good.
Yeah.
Nice preparation, and we have covered the whole gambit of medical in the previous discussion and surgical in the present discussion. Thank you very much. Have a nice weekend. We will start a different table in the next few days' time.
Yeah, lovely. Thank you very much, Mr. D. I appreciate your
Bye.
time. Thank you. Bye-bye.